is a very important GI emergency. So coming to the upper GI bleed, coming to the incidence of upper GI versus lower GI bleed, the incidence is 5:1 compared to the lower GI bleeding, and the incidence is 170 patients per 1 lakh population per year we see. And the most common cause for the upper GI bleed is peptic ulcer that constitutes about 40%. And one important thing is that one good thing in the upper GI bleed is most of the bleeds are self-limited, 80% are self-limited bleeds. And the patients on antiplatelet therapy has twofold increase in bleed as compared to normal ones. And there is annual upper GI bleed incidence of 30%. And 20% of patients of moderate to high risk who have recurrent bleeding within 48 to 72 hours. 48 to 72 hours have poor prognosis, and the mortality rate is about 5 to 10% for severe upper GI bleed. So coming to the definition of severe GI bleeding. Severe GI bleeding is defined as documented GI bleeding, that is hematemesis, melena, hematochezia, or positive nasogastric lavage. And this is accompanied by shock or orthostatic hypotension, a decrease in the hematocrit value by at least 6%, or a decrease in the hemoglobin level of at least 2 grams per deciliter, or transfusion of at least 2 units of active red blood cells. This is the definition of severe GI bleed. So coming to the classification of GI bleed, according to the level of bleeding, it is classified as upper and lower GI bleed. Upper GI bleed is above the ligament of Treat, and below is the below ligament of Treat. Lower GI bleed is the below ligament of Treat. And time is whether it is acute or chronic. Acute mainly they present with hematemesis, melena, or hematochezia. Chronic bleeds are mostly they present with chronic symptoms of anemia. And based on the severity of blood loss also there is a classification. Coming to the definitions, the upper GI bleed is arising from the esophagus, stomach, or proximal duodenum, and mid-intestinal bleed is arising from the distal duodenum to ileocecal valve, and lower intestinal bleed is arising from the colon or rectum. So coming to the clinical presentation of upper GI bleed, it can be hematemesis. Hematemesis is like coffee ground or bright red color. If it is a bright red blood in the bleeding, then it is signifies of moderate to severe bleeding. And if it is a coffee ground emesis, that indicates slower bleed. And melena is passing of dark, tarry, pungent stools. And melena can signify bleeding that originates from the upper GI, small bowel, or proximal colonic source, and generally occurs when 50 to 100 ml or more of blood is delivered into the GI tract, usually the upper GI tract, and with passage of characteristic stool occurring several hours after the bleeding event. So minimum 50 to 100 ml of blood is needed to pass melena, and hematochezia is the passing of bright red blood, and it is mostly usually lower GI blood, but it can be seen with massive or brisk upper GI bleeding. The massive and brisk upper GI bleeding can also cause hematochezia. So coming to the causes of upper GI bleeding, common causes are peptic ulcer, erosive mucosal disease, gastric varices, biliary vestibular, intensive care setup. This can lead to stress ulcers, and this can lead to GI bleeds. And occasional causes are esophagitis, upper GI neoplasms like esophageal carcinoma and gastric carcinoma, and caustic injury, ingestion of caustic substance, and vascular anomalies like Osler-Rendu-Weber syndrome and some other causes, coagulopathy, stromal ulcers, portal hypertensive gastropathy, and hemophilia can also present as upper GI bleed. And rare causes are vasculoenteric fistulas and post-endoscopic procedures. Sometimes during ERCP we do sphincterotomy. Sometimes they can present as a sphincterotomy, post-sphincterotomy bleed, they can present as upper GI bleed. And some systemic diseases they can present with upper GI bleeds. So some of the clinical features, based on the clinical features, we can know the etiology of the upper GI bleed. These are some of the features of these upper GI lesions. If it is a peptic ulcer bleed, mostly they present with epigastric burning pain. If it is a varicose bleed, patient may present with right upper quadrant pain, fever, nausea, vomitings, and ascites, edema, and features of hepatic failure. These ascites, edema these are stigmata of chronic liver disease. So if there is a patient with stigmata of chronic liver disease, mostly we have to suspect varicose bleed. And esophagitis can lead to upper GI bleed. In this patient, give history of heartburn, regurgitation, chest pain, dysphagia, odonophagia, and globus sensation. And malrevestier can present with upper GI bleed. This indicates in patient give history of excessive retching, vomiting, or coughing, preceding hematemesis after alcohol intake. If there is any patient with alcohol intake and if the preceding vomiting and later patient develops upper GI bleed with vomiting, then it indicates malrevestier. So coming to the consequences of blood loss can be slow or rapid. Slow blood loss, mostly they present like features of anemia like giddiness, weakness, sweating, and effort intolerance. And if it is a rapid, then patient leads to can have vasoconstriction. This presents as a pale, cold sweats, tachycardia, and tachypnea. And later they may develop vasodilatation. This presents as a sweating, motor weakness, altered sensorium. And then later they can go to reversible shock. And if we don't intervene, then they may develop irreversible shock and organ failure. So these are some classes of acute hemorrhages. There are 4 classes: class 1, class 2, class 3, and class 4. This is based on the amount of blood loss. If the blood loss is less than 750, there is class 1, class 2, 750 to 1500 ml. And class 4 is more than 2000 cc. And if, class 1 is the mostly it is a minor bleed. Class 2 somewhat class 2 is not that major bleed. Class 3 and class 4 are major bleeds. And if you see the fluid requirement, mostly class 1 and class 2 they require the crystalloids, and in class 3, class 4 we have to give both crystalloids and blood. So it is if the patient presents to the casualty, it is very important to know who are the patients they require more attention and who are the patients they require less attention and they can be sent from the casualty. There are some risk factors and some risk stratification strategies are there. And this is mainly for non-varicose bleeding. And this may be categorized as low, intermediate, and high risk. There are some scores are there. The pre-endoscopy scoring systems are Blatchford score. In this, the constituent components are BP, bun level, is hemoglobin, heart rate, syncope, melena, liver disease, and heart failure. And clinical Rakal score. This is constituents of this score are patient's age, shock, and coexisting illnesses, and artificial neural network score. There are 21 variables in this score. And post endoscopy scoring system, that is complete Rakal score, that is clinical Rakal score plus endoscopic findings. And this correlates well with mortality and the risk of rebleeding. So this is the Blatchford scoring system. This is the pre-endoscopic assessment. These are the variables are systolic blood pressure, bun, hemoglobin, and other variables like pulse rate, presentation with melena, hepatic disease, and cardiac failure. And most patients need intervention if the score is 6 or higher. If the patient score is 6 or higher, then the patient needs more intensive treatment. So this is the Rakal score. In this, the components are age, shock, major comorbidity, evidence of bleeding, and diagnosis. If the score is less than 3, it carries good prognosis. And if the score is more than 8, it carries high risk of mortality. So this is the diagram showing the clinical Rakal score and their mortality rates. If the Rakal score is only 1, the mortality is very low, about 2 to 3%. If the Rakal score is 7, the mortality is very high with 50% of mortality is seen in these patients. So another score is AIM-65. This is simple risk score that predicts in-hospital mortality, length of hospital stay, and cost in patients with acute upper GI bleed. there are these different components are there. Albumin less than 3, INR more than 1.5, mental status altered, and systolic BP of less than 90 and 65 years old, more than 65 years old. The score is more than 2, then that carries bad prognosis. So once the patient present with upper GI bleed, when should a gastroenterologist to be consulted in the evaluation of acute GI bleeding? This is the question. We have to consult as early as possible, mainly to consider prompt endoscopy and facilitate triage. And most important initial diagnostic test of choice is esophagogastroduodenoscopy, that is upper GI endoscopy. And mainly esophagogastroduodenoscopy is useful for patient presented with melena and hematemesis, and for subsets of patients with hematochezia from the upper GI source. In these patients, upper GI endoscope is very useful. And early endoscopy is required in some patients in the less than 24 hours of admission. This is mainly for upper GI bleeding, but before doing endoscopy, you have to ensure that volume is resuscitated and the hemodynamic stability is achieved in these patients. And urgent endoscopy is less than 12 hours of admission. This is mainly done in patients with suspected variceal bleeding, and it provides valuable information for appropriate triage. So there is a role for prokinetic medications also in the upper GI bleed. Mainly they facilitate clearance of blood and clots from the stomach. Commonly used prokinetics are erythromycin and metoclopramide, and this is administered IV 20 to 120 minutes before upper endoscopy. Mainly these prokinetic drugs, they propulse the food and they improve the endoscopic visualization, but it does not appear to alter the important clinical outcomes with the prokinetics. And this is reserved for only with red blood hematemesis or blood in the nasogastric aspirate. Mainly these patients, they require prokinetics. So some of the tests, these are helpful in the evaluation of the upper GI bleed. If we do upper GI and colonoscopy and if they don't see any bleeding source, these are some of the adjuvant tests that are useful in the GI bleed. First one is the wireless video capsule endoscopy. This is carries very higher diagnostic yield of 35 to 76%. But main disadvantage of this test is it cannot provide hemostatic interventions. Only this diagnose the condition, but it cannot. We cannot do any interventions. And in many institutions, they cannot perform urgent video capsule endoscopy. Next one is the angiography. Sometimes we don't see in Dulophy's lesion, all these lesions, we cannot see the bleeding source exactly. In that, angiography is useful. And if there is any lesion is there, we can intervene also with angiography. But the main disadvantage of this is it requires very active bleeding at the time of study of 0.5 ml per minute. Sometimes CT and CT-MR angiography are also useful in the evaluation of the GI bleed. And one more useful test is the radionuclide scanning. And this also detects bleeding at a rate of 0.044 ml per minute. Technetium sulfur colloid and technetium pertechnic scans are labeled with RBC, and these can be done. In the main, if there is any acute bleeding, technetium sulfur colloid scanning is more useful. So another important thing in the management of upper GI bleed is the insertion of a NG tube. The presence of red blood in the NG aspirate is an advanced prognostic sign that indicates the patient is actively bleeding. But one more thing is 15% of patients without bloody or coffee ground material in the NG aspirates are found to have high risk lesions on endoscopy. Sometimes NG aspirate may be normal, bilious or something, but we found very high risk lesions on endoscopy. The use of a large bore tube with gastric lavage, it improves visualization of the gastric fundus on endoscopy, but it does not improve the outcome. And there is no role for occult blood testing of aspirate in the routine practice. And some misconception is acid saline is useful in the gastric lavage, but the acid saline gastric lavage is ineffective in reducing any rebleeding. So normal room temperature saline is enough for the gastric lavage. So coming to the important cause of upper GI bleed, that is peptic ulcer disease. In the total peptic ulcer disease, 5% of patients they can present as hemorrhage as the presenting symptom, and more 20% of peptic ulcer disease they develop bleeding at least once, and hemorrhage is the lethal most complication of the ulcer disease. Other complications are like perforation and all the things, but hemorrhage is the lethal complication. So coming to the pathogenesis of peptic disease, acid peptic erosions into submucosal or extraluminal vessels. Helicobacter pylori is the most common etiology for duodenal ulcer. NSAIDs are the also other causes of for peptic disease, and they damage the GI mucosa, and inhibition of prostaglandin synthesis, inhibition of mucus and bicarbonate production. It delay ulcer healing, epithelial acidification, and platelet dysfunction. These all can lead to ulcer disease formation. And Zollinger-Ensel syndrome, this is the gastrin secreting tumor. This can also lead to peptic ulcers. So some of the prognostic factors in peptic ulcer disease are the severity of bleeding and hemodynamic status, and whether it is bleeding is persistent or recurrent bleeding. And if the more transfusions are required, then that is indicates the poor prognosis. And a nasogastric aspirate, if it is a blood or that indicates poor prognosis. If it is a coffee ground, then that indicates slower bleeding. And older patients, they carry bad prognosis. And comorbid, if it patient associated with comorbidities, then that also carries bad prognosis. So coming to the gastric ulcers, in the whole of the gastric ulcers, 10% of gastric ulcers are malignant, and most of bleeding ulcers arise in incisura, antrum, and distal body of stomach. So duodenal ulcer, this is the commonest cause for the duodenal ulcer is the Helicobacter pylori. 95% of duodenal ulcers are associated with the Helicobacter pylori infection, and 10% of patients with the HP and Helicobacter pylori infection develop ulcer, and 20% of patients with ulcer and HP bleed. And bleeding duodenal ulcer is usually located on the posterior duodenal wall because of gastroduodenal artery is present in the posterior duodenal wall. So early endoscopy is the cornerstone of treatment in the GI bleed, and it is better to perform within 24 hours. And it improves certain outcomes, the number of units of blood transfused and the length of the hospital stay. And it determines the cause of bleeding, ascertain prognosis, and administered endoscopic therapy. And the treatment recommendations are focused that on the first 72 hours after presentation and endoscopic evaluation and therapy, since this is the period when the risk of rebleeding is greatest. So more than 90% of rebleeding occurs in the first 72 hours. So this 72 hours is the crucial period in the upper GI bleed patients. So this is a diagram showing the stigmata of bleeding and risk for bleeding prevalence. In this you can see majority of this is the clean base ulcer, and of the ulcer is clean based ulcer. This is the dot. This is the flat pigmented spot. This is constitutes about 23%, and this is the clot. This is clot constitutes 13%. Non-bleeding visible vessel. This is the non-bleeding visible vessel. It constitutes 8%, and bleeder is actively bleeding vessel. You can see it constitutes 7%. So this is the risk of rebleeding in the according to this endoscopic appearance. If there is any active bleeder, there is chance of risk of rebleeding of more than 60% in 72 hours. If there is any non-bleeding visible vessel, you see on endoscopy, there is a risk of rebleeding of 44%. If it is a clot, then it is a risk of rebleeding is 23%. If it is dot, the risk of rebleeding is only 10%. If it is a clean base, the risk of bleeding is only 5%. So based on the endoscopic appearance of the ulcer, we can know the risk of rebleeding, and accordingly we can plan the treatment. So this is the endoscopic risk stratification. If the endoscopic active bleeding is there, rebleeding is 55%, and mortality, it carries high mortality of 11%. Visible vessel 43 and 11% of mortality. Adherent clot 22% and 7% of mortality. Rebleed is 22 and mortality. Flat spot only 3% mortality. Clean answer base, it carries only 2% mortality. So after patient coming to the emergency, administration of proton pump inhibitor is very important. And the use of high dose oral PPI or IV PPI in peptic ulcer bleeding has been shown in Asian patients. The reductions in the risk of rebleeding, the need for surgery, and the risk of death. All rebleeding, surgery rate, and death all are decreased with the early treatment with the proton pump inhibitor. And these results may not be completely generalizable to North American or European population. These studies are mainly they are conducted in the Asian populations. And one more thing important in the management is the second look endoscopy. When the patients after doing the endoscopy, is there any need for second look endoscopy? This is the second look endoscopy is the planned second look endoscopy that is performed within 22 hours after initial endoscopic therapy, and it has not been recommended routinely. Provided only a limited reduction in the rate of rebleeding, and it may not be cost effective when medical therapy leading to profound acid suppression is used. So after invention of PPIs, there is the endoscopy, second look endoscopy use is much lesser, and repeat endoscopy may be considered only on a case by case basis. And if you are suspecting if there is any recurrent bleeding and if there are any clinical signs of recurrent bleeding or you are suspecting, then you may have to do the second look endoscopy. And if there is uncertainty regarding the effectiveness of hemostasis during the insult treatment, if you are not sure about the control of blood during the insult endoscopy, then you may do. It is better to do second look endoscopy. So this is the flow diagram showing the triage of upper GI bleeding. Upper GI mainly it is for non-varicose. The hemodynamically stable hemodynamics. If Blatchford score is less than 2, it constitutes about 10% of patients. Outpatient care elective endoscopy is enough for these patients, and we have to start PPIs. And definitive care is based on the endoscopic findings. If the endoscopy showed high risk stigmata, then endoscopic therapy you have to give. And if there is no high risk stigmata, outpatient therapy is enough for these patients. If Blatchford score is more than 2, mostly 90% of patients are with more than 2 Blatchford score, we have to do the urgent endoscopy. And we have to assess for the Racal score also. If it is less than 3, 20 to 30% of patients constitute this group, and it can be done on treatment can be done on outpatient level, that is with PPI and followed by the H. pylori treatment. If there are any high risk stigmata, you have to do the endoscopic therapy, and patient has to be in the hospital ICU care based therapy based on the comorbidity. So some of the interventions are very useful in the management of acute GI bleeding. This is there is aggressive volume resuscitation is very useful in these patients. Large bore peripheral IV catheters to give fluids and blood products rapidly, and if it is sometimes patient may need intubation because there may be chances of vomiting and there may be chances of aspiration. So if there are patient mental status is not proper, then it is better to intubate the patients. And isotonic eye fluids to replenish the intravascular volume. And massive transfusion of blood also sometimes it is harmful to these patients. And treat coagulopathy in patients receiving anticoagulants. Don't delay therapeutic endoscopy unless INR is more than 2.5. And except in cirrhosis, INR cannot predict the bleeding risk. So target platelet count should be more than 50,000 if there is no platelet dysfunction. If there is any platelet dysfunction is there suspected, then it is better to have platelet count of more than 1 lakh. So this is the meta-analysis showing the comparison of restrictive versus liberal blood transfusion. This current US guidelines recommend transfusion is at a threshold of hemoglobin 70 grams per liter for hemodynamically stable adult in patients and 80 grams for those undergoing orthopedic cardiac surgery or with pre-existing cardiovascular disease. So this is the diagram showing the mortality and rebleeding rate, and if both the things, if the favors restrictive transfusions, So you should not give excessive blood. Only 7 grams per liter is 70 grams per liter is enough. Maintaining 70 grams per liter is enough for hemodynamically stable patients, and for 80 grams per liter is enough for the cardiovascular disease patients. So we should not do aggressive transfusion, blood transfusions. So coming to the upper GI bleeding management, and endoscopy is plays very important role. Mainly, it allows the biopsy and it assesses the cause of the bleeding. And according to the Forest classification, is very useful in managing the peptic ulcer bleed. It describes ulcers and predicts the risk. Clean base ulcer or flat pigmented spot in ulcer base that indicates low bleeding risk. Pharmacological treatment is enough for these patients. If there are adherent clots, non-bleeding visible vessels, or active bleeding, high risk continued or recurrent bleeding is the risk is there. So endoscopic interventions and pharmacological treatment both are needed in these high risk patients. So high risk in lesions, if the high risk lesions are seen in endoscopic therapy, then it is better to be keep the patient in hospital at least for 3 days, and we have to give IV PPIs, and later we can, after 3 days, we can start them on oral PPI. Low risk lesions, if the patient is hemodynamically stable, if there are no serious comorbidities, we can consider early discharge and we can keep the patient on daily proton pump inhibitor. So, and we are immediately after a patient coming to the hospital, it is better to give PPIs irrespective of the cause of the upper GI bleed. So some of the instructions are important after treating the acute GI bleed during the follow-up, and we have to look for mainly signs and symptoms of recurrent GI bleed, and we have to do the benefit and duration of the targeted therapies. And if the bleeding is from H. pylori related ulcer, you have to treat the complete therapy, and then we have to treat the H. pylori and discharge the patient. And PPI only indicated if the unless if the NSAIDs and antiplatelet treatment is needed, then only you have to give PPI. Otherwise, after treating H. pylori, there is no need to continue PPI in these patients. And if the ulcer is related to NSAIDs, it is better to discontinue NSAIDs if feasible. And if patient is on low dose aspirin, and it is we can resume the low dose after aspirin after bleeding stops for secondary prevention of established cardiovascular disease. If the aspirin or clopidogrel for primary prevention of CV events, you have to weigh risks and benefits on individual basis. So for primary prevention, if the patient develops ulcer, it is better not to give aspirin or clopidogrel. And dual antiplatelets, if the patient has to continue dual antiplatelet treatment, PPI prophylaxis is recommended as long as dual antiplatelet treatment is indicated. And if bleeding is not associated with H. pylori, NSAIDs or antiplatelet agents, it is better to continue daily PPI indefinitely. So these are some of the endoscopic modalities available for the management of upper GI bleed. There are three types of therapies are there: injection therapies, thermal therapies, and mechanical therapies. Injection, these are the mainly modalities that can control that we can control with the we can control the GI bleed during endoscopic management. Injections are adrenaline, fibrin glue, human thrombin, sclerogens, alcohol. Thermal are heater probe, bicap probe, gold probe, organ plasma coagulation, and laser therapy. Mechanical are hemoclips, banding, endoloops, staples, and sutures. So coming to the endoscopic therapy of injection, this is the main mechanism of action in this therapy is it reduces blood flow by temporary local tamponade, and vasoconstricting agents they reduce the blood flow. Adrenaline 1:10,000 is used in these patients, and sclerogens that are useful in the controlling the bleed are ethanolamine and polidocanol, and some tissue adhesives are also useful. This is like histoacryl and fibrin. So this is the ablative therapies, endoscopic therapy, ablative therapies that are useful in the controlling of GA peptic ulcer bleed. These contact ablative therapies are thermocoagulation heat probe, electrocoagulation bicap gold probe, non-contact ablative therapies like argon plasma coagulation. So this is the video showing the application of argon plasma coagulation in a gastric ulcer. You can see this is the gastric ulcer. This is the gastric ulcer. According to Forest classification, it is looking like non-bleeding visible vessel. So we are applying this argon plasma coagulation. This is a non-contact ablative therapy. So if it is, if we are using non-contact thermal therapy, it is better to use combined therapy. We can use both injection with the adrenaline, and then we can use the contact therapy. This thermal therapies. Thermal therapies are argon plasma coagulation, gold probe application, and bicap methods. So this is the hemoclip applications. These are the hemoclips. This works by mechanical methods. With the we can cast the bleeding vessel with the hemoclips. So this is a case of gastric dwellophis lesion. You can see the vessel here and with the adherent clot. So we can apply the clips onto this vessel, and with that we can control the bleed. We can sometimes one clip is enough, but in this case we have applied 3 clips. So with this, if you are using mechanical method, sometimes only a single modality of treatment is enough. If you're using thermal therapies and injection therapies, sometimes it is better to use 2 modalities of treatment. In this, we have used only clips, and that patient bleeding got controlled. So this is the combination therapy. If it is only injection therapy is not effective, we have to combine with thermocoagulation therapy. So both if you give both methods as treatment, that is more effective. We give first adrenaline, then we use a combination probe, and sometimes we may inject and clip. So this is the summary of the management of peptic ulcer bleed. If it is an active arterial bleeding, that is Forest 1A, 1B, and in this endoscopic treatment we have to give, and IV proton pump inhibitor infusion for 72 hours. If it is a non-bleeding vessel, that is Forest 2A, we have to give endoscopic therapy and IV PPA for 72 hours. If it is adherent clot, we have to give both endoscopic therapy and IV PPA for 72 hours. If the in an endoscopy is, if you see only flat red black spots and are clean base and there is no stigmata, there is no need for any endoscopic therapy. Only we can give oral PPA, and we can discharge we can send the patient home. So these are the only these Forest 1A, 1B, Forest 2A, and Forest 2B. These group of patients only, they require the endoscopic therapy and IV IV proton pump inhibitor infusion. So some of the newer methods in controlling the GA bleed is the Ovesco clip application. The Ovesco, previously we have seen the clips that are through the scope, we will apply the clips. This is the over the scope, we mount the clip and we will apply the clip to the bleeding vessel. So in this, it was a very large ulcer, and it was not, and it is fibrosed ulcer. So we are unable to do the clipping with the routine through the scope clips. So this in view of large size and in view of fibrosed base, so it is very difficult. It was very difficult to control the bleed. So in this case, these are the very useful. This is the Ovesco clip up to 2 centimeter of ulcer also we can hold, and we can now you can see the clip. So with this we can control the bleed effectively. So another new addition into the endoscopic therapy is hemospray. Hemospray is some mineral powder. We spray onto the surface of the bleeding vessel or bleeding surface, and it it absorbs the water from the surface, and it attracts the platelets and the clotting factors to the that area, and that forms the coagulant. This is a video. In this, we have used this hemospray in a patient of. This is a case of big gastric carcinoma. Patient was oozing from the carcinoma surface. So in this, it was very difficult to control the bleed with the routine methods like argan plasma coagulation or this clips or this. So we have applied. You can see the spray. As white one is the spray. So with this, we have sprayed all the lesion, and then we can see there is a control of bleed with this. So in a desperate situation, sometimes it is very useful. If the other but it gives only temporary relief. But it is at least in the emergency we can use all these methods. So post endoscopic therapy is also very useful. Follow up is also very useful. Some patients, they may require surgery also when the endoscopic second endoscopy attempt is failed. And some patients, they may require angiography to control the bleed. If the bleed is not controlled with endoscopic method, then angiography is one more option for the control of bleed. And the anti-secretory treatment also we have to give during the post endoscopic treatment. And after that, if the patient is positive for H. pylori, we have to give the H. pylori eradication treatment. So this is next, coming to the Mallory-West tears. This is also one of the important cause for the upper GI bleed. This is a tear in the gastric mucosa near GE junction. This is characterized by antecedent history of vomiting, retching, or coughing, and they are commonly associated with alcoholism, NSAID intake, and hypertonia, and more than 60. These are all people, they are more prone to develop Mallory-West tear. Coming to the treatment of Mallory-West tear, most of the times it stops spontaneously. In 90%, it stops spontaneously. Needed for the diagnosis and treatment. Patients with active initial endoscopy or patients with anticoagulation disorders, there is a chance of rebleeding in these patients, and surgery is rarely needed, like gastrotomy and oversewing of the mucosal tear. These are the two surgical methods. Dulophy's lesion. This is also one of the cause for this upper GI bleed. There is aberrant submucosal vessel seen in the lesser curve of the stomach. Treatment is endoscopic or surgery. Endoscopic diagnosis is difficult because it is only vessel is bleeding, so there is no ulcerated lesion. Sometimes it is very difficult to localize the bleeding spot, and rebleeding is very common in these patients. So this is one of the case of gastric antral vascular ectasia. Mostly we see in this game in the CLD, chronic liver disease patients. Sometimes we can see in the normal patients also. So this is like watermelon stomach. You can see this is the most of the patients. These patients, they don't present with acute bleed, but they may present with anemia like thing. On endoscopy, we can see this is the watermelon stomach. We are applying argan plasma coagulation to these lesions. This is a superficial coagulation of these lesions, and sometimes with one session they may not be controlled. They may need 2 to 3 sessions. And other modalities for the treatment of gastric antral vasculitis, we can band these lesions. We can apply rubber bands to all these lesions. That can also control this gastric antral vascular ectasia. So now we are applying argan plasma coagulation for these lesions. So coming to the one of the most another important cause for the upper GI bleed is the esophageal varices. So coming to the pathogenesis of esophageal varices, there is elevated portal venous pressure, hepatic venous pressure gradient of more than 12 mmHg. Then the patient develops varices. The risk of hemorrhage is more if the size of the varix is large, and if there is any red color signs on endoscopy, and there is any poor liver function, and if there is any active alcohol use in these patients, then the chances of bleeding is more. So varicose bleeding, it occurs in 1/3 of patients with cirrhosis. 1/3 initial bleeding episodes are fatal, and among survivors, 1/3 will rebleed within 6 weeks, and only 1/3 will survive 1 year or more. This is the 1/3 formula. So coming to the variceal bleed management, these are very important uh, um, parameters in the variceal bleed management. One is the vasoconstrictor therapy, antibiotics, resuscitation, ICU level care, endoscopy, alternative and rescue therapies, and beta blockers. So vasoconstrict initially after coming, patient comes to the casualty. If you are suspecting variceal bleed and if there are any stigmata of chronic liver disease, you can start them on vasoconstrictor therapy. And main goal is to reduce the splanchnic blood flow. Terlipressin is the only agent shown to improve control of bleeding and survival in randomized controlled trials and meta-analysis. But with terlipressin, there are side effects. If there is any CID, it is you have to give with very carefully. They can lead to myocardial infarctions. And vasopressin and nitroglycerin also they have tried, but there are too many adverse effects to this combination therapy. And somatostatin and octreotide are other agents. Mainly they work by decreasing the splanchnic blood flow. And standard dose of octreotide therapy is 50 micrograms bolus, then 50 micrograms per hour drip for 3 to 5 days. So coming to the acute esophageal variceal bleeding, we have to because it is because of significant portal hypertension it occurs. So bleeding occurs under high pressure and often brisk. You can see the brisk bleeding during the endoscopy. We have to monitor closely for adverse effects of volume replacement because already they are volume overloaded because of ascites and all the things. And we should target hemoglobin only for 7 to 8 grams per deciliter. Antibiotic prophylaxis we should give to all the patients with variceal bleed to reduce infectious complications. Because of hypovolemia, there may be chances of hypoperfusion of intestines, and there may be bacterial translocation of bacteria to the ascites, so they may develop spontaneous bacterial peritonitis. So every patient of cirrhosis with variceal bleed, you have to administer antibiotics. And medical treatment is infusion of octreotides, somatostatin analogs. Endoscopy is the therapy is for if the variceal bleed we are suspecting, then like banding and for esophageal varices and glue injection for gastric varices. And if the bleeding is refractory to medical and endoscopic therapy, then we have to consider think of other alternatives like balloon tamponade, sense taken tube placement, tips placement. This is transjugular intrahepatic porta systemic shunt placement. This like interventional radiologists, they do this procedure. And another alternative is the surgery. This is like portosystemic shunting with esophageal transection and liver transplant. So this is the case of esophageal variceal bleeding. In this patient, we have applied bleeding. You can see the brisk bleeding coming from the esophagus. You can see that it is like tap. It is bleeding. We have applied bands. This is the rubber bands. These are varices we see in the esophagus, esophageal varices. First, we have to start the banding at the GE junction because the feeding of the vessel is from the below upwards. So first we have to block the vessel at the GE junction, and then we can apply the band on the upper side of the esophagus. So this is the rescue therapy of the esophageal or gastric variceal bleed. This is transjugular intrahepatic portosystemic shunt. This early placement of shunt associated with improved survival among high-risk patients. And this is the preferred treatment for gastric variceal bleeding. Sometimes gastric variceal bleedings are very difficult to control. So TIPS is the very effective modality to control the gastric variceal bleed. Other modalities are like placing of sense taken black mode tube. If there is no availability of endoscopy and if there is no availability of trained personnel, in the peripheries also we can put these tubes. That is the advantage of this tube, but it is very effective for immediate and temporary control. But it is associated with high complication like rate like aspiration, migration, necrosis, and perforation of esophagus. And it acts as a bridge to TIPS within 24 hours, and it acts as a bridge to the endoscopic therapy also. And airway protection is strongly recommended. and it is better not to keep the tube more than 24 hours. It mainly works as a emergency procedure. So this is the Seng's taken tube. It controls bleeding almost in 90% of esophageal variceal bleeding. This is the balloon tamponade of Seng's taken tube. So some alternatives are, we can put the self-expanding metal stents also. This is specially designed covered metal stent. It tamponates the distal esophageal varices and it is removable, does not require any airway protection, but there is limited data. With this stents also we can control the variceal bleed. So this is the glue injection for gastric varices. For esophageal varices we apply bands, but gastric varices we don't apply bands. We inject glue. Glue is cyanoacrylate glue. This is a substance which after coming into contact with the blood, it solidifies. So that's why so it is the gastric varix. You can see that stigmata of recent hemorrhage like clot on the varix. So we have applied glue in these patients. You can see the needle, and we are injecting glue in these patients. This after injecting glue, that glue after coming contact with the blood, it becomes solidifies. By that, it halts the this circulation, and with that we can control the GI bleed, gastric variceal bleed. So you can see we are injecting the glue. There is some extravasation of glue. You can see it is the glue that is coming out during the injection. So in this way we can control the gastric variceal bleed. Because gastric variceal bleeds are sometimes very torrential bleeds, and the TIPS is one of the very important alternative for controlling of the gastric variceal bleed. One more development in the management of gastric variceal bleed. This is a US guided image of the gastric varix. So you can see these are all gastric varices. But main problem with the gastric glue is that there is complication. There is a sometimes patient may develop thromboembolism, pulmonary thromboembolism that can lead to immediate death. So to prevent that complication, we are injecting you can see the needle in the gastric varix. We are putting the coils in this gastric varix. After putting the coil, we inject the glue. So by putting the coil, we can avoid the complication of pulmonary thromboembolism. So that by that way we can decrease the risk of pulmonary thromboembolism, and this is more control. How this under vision we can see how much is whether the bleed flow is there or not, whether the varix is completely obliterated or not. We can see under direct vision. So this we are putting first we are putting this coil in this. So you can see this coil we have applied into we have delivered into the gastric varix, and we are injecting glue also into this. And post procedure we can apply the Doppler, and we can see whether the flow is obliterated or not. Now we are applying the Doppler. Then we can see. So this is now previously you used to see some hypoechoic varices. Now you can see this is all obliterated. Now you can see there is no flow. So beta blockade therapy is also very important in reducing the risk of recurrent variceal hemorrhages. Use of non-selective beta blockers like propranolol is useful. It decreases the splanchnic vasoconstriction, decreases the cardiac output, and decreases the rebleeding rates. You have to titrate the dose of heart rate should be around 50 to 60. Recently, we are giving carvedilol also for this patients to prevent recurrence of variceal bleed. So surgical portosystemic stent is another alternative of controlling bleed in the variceal bleed. But it carries very high mortality rate as emergency procedures. There are two portosystemic shunts, non-selective and selective. But with non-selective, there is chance of greater risk for hepatic encephalopathy. But these are very effective for ascites control. But selective, this is more preferable for variceal bleed. But And and procedure of choice is the distal splenorenal shunt. This is the procedure of choice. Another surgery is the devascularization procedure. And if shunt procedure is not possible, then devascularization of the lower esophagus is also one of the surgical method that can control the variceal bleed. So coming to the upper GI bleed, the points to remember are nil per mouth, and check sensorium and vitals, oxygen supplementation, resuscitate the patient, RT placement and gastric lavage, send blood samples, start PPI infusion 80 mg start, then at the rate of 8 mg per hour. If variceal bleed you are suspecting, then start the patient on somatostatin or octreotide. Somatostatin in the dose of 250 micrograms stat followed by 250 micrograms per hour infusion. And injection telepressin also, if there are no cardiac problems are there, if there is no CID you are suspecting, then we can start the patient on telepressin, 2 milligram IV stat, then 1 milligram every 6th hourly. Other points to remember are whether we have to see whether a nasogastric tube is showing blood or coffee ground color to assess the severity of the bleed. And if there is any melena, you can do the rectal exam also sometimes. And after stabilization and primary treatment, upper GI endoscopy to be done within 12 to 24 hours. And specific treatment like medical treatment, antibiotics, endoscopy, angiography, and surgery. There are other alternatives. And some of the points are IV fluids we have to give, and if there is any NSAIDs or intake history is there, we have to stop NSAIDs. And anti-secretory agents like proton pump inhibitors are very important. And PPIs may reduce rebleeding. Endoscopy diagnostic and therapeutic within 12 to 24 hours. Anti-expellatory treatment we have to do, but not immediately. After stabilization of the patient, we can start the anti-expellatory treatment. And if there is any massive bleeding, it is better to consider the patient for emergent endoscopy. Thank you very much for your patient hearing. If there are any questions, I am happy to take. Sir, you are muted, sir.
Right. Yeah. Thank you, Dr. Chandrasekhar Reddy, and extensive talk. This is useful for the DNBs of medicine as well as gastroenterology and then consultation also. And I'm sorry I could not introduce Dr. Chandrasekhar Reddy because of the technical faulty, my coming onto the screen. But however, besides thanking and before asking the students for interaction and then questions, I'd like to introduce Dr. Chandrasekhar Reddy, who has got vast experience of 17 years. And then he's the head of the Department of Gastroenterology at Yashoda Hospital, Somajiguda. He did his MBBS and MD from Carmel Medical College, and then DM from the Usmania Medical College. And then he is a life member of the Indian Society of Gastroenterology, life member Indian National Association of Study of the Liver, member American Society of Gastrointestinal Endoscopy, with his vast experience in endoscopies as well as upper GI and then lower. And he is one of the good teacher we have. And then I request the students to please clarify their doubts. And then if they want to add anything, they are also most welcome. I think I don't know how many participants still left. Hello. సాధ్యమ్మా అవును పర్లేదు నేను నేనేమన్నాను తీసుకెళ్ళి
సార్
నా దగ్గర డిస్కనెక్ట్ అయిపోయింది మీరు కంక్లూడ్ చేయండి
సరే సార్ హలో సార్
హలో
సార్
it got disconnected from my side. So if there are any questions, there are no questions, I think should we conclude?
Okay, sir. Thank you for giving me the opportunity to Dr. Balaraj sir and DNB board. Sir, are you?
Yeah,
sir?
Yeah.
Okay. Thank you for giving me the opportunity, Dr. Balaraj sir and Dr. DNB board for giving me the opportunity.
And then I think such occasions will be much more, sir. So I request you to kindly help us.
Okay.
For the Association of National Board of Accreditation.
Okay. Thank you, sir. Thank you very much. Sir.
Thank you, Dr. Srinath, if you are there. Thank you, sir. We'll close it. Thank you.